everyone, Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This next section of the Billing and Coding course has to do with global maternity care. If a midwife is going to bill to an insurance company, this is a majority of the billing and coding content they will be submitting to the insurance plan. Legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational purposes only. It's not intended to substitute for professional, legal, or clinical advice. We strive to provide you the most timely and accurate information possible, but we make no claims, promises, or guarantees of the accuracy and adequacy of the information and disclaim liabilities for errors and omissions. This course objective is going to be around what exactly is maternity care, what are the codes affiliated with it, the diagnosis, the CPT codes, the services included in global maternity, what's not included in global maternity, if someone transfers to you, how do you split up the charges, if you have to collaborate with a physician, they need to go to the hospital and get delivery at the facility, or C-section and you continue the postpartum care. How do you break all of that up? Some of the common services included, not included, we'll go over those. If you're going to bill antepartum care, just the prenatal visits, what are the breakdown of those charges? Students will also be able to verbalize if you're going to do just parts of it. We gave the example of transferring care, charging tips for insurance plans. If they have a new open enrollment, in the first couple prenatal visits, they had one insurance plan and then they switched over to another. There are situations where there's high risk pregnancy management. If you're collaborating with a physician, you have to do extra prenatal care above and beyond the 7 to 12 routine prenatal visits. There's some additional charges you can put out there. Most midwives are going to be low risk healthy, but I just want them to be aware of there are some additional management enhancement charges available on top of the global maternity charges. So what exactly is maternity care billing? It has to do with taking care of a pregnant person from their initial prenatal visit all the way till 6 weeks postpartum. It can be broken up into sections, but if you're traditionally billing the global maternity care, it encompasses the delivery, the postpartum, the prenatal visits, the routine management. If you're helping with primary care, you're doing above and beyond what a traditional doctor's office, medical, hospital facility offers. Those are additional separate charges. They're traditionally reimbursed by one provider, but if there is a transfer of care, someone moves to the area, they switch insurance plans, many times you have to bill whatever dates of service were under that plan or whoever was taking care of them. So traditional uncomplicated normal maternity care has to do with code 59400, and that's the routine vaginal delivery, prenatal visits, no significant tear, routine labor management, postpartum care. 59510 has to do with the routine care of a C-section. They ended up, and that's traditionally going to be an obstetrician. No midwife that I'm aware of delivers by cesarean section, so that code wouldn't be applicable to the midwives. But if you work in a doctor's office and you're billing under a supervising provider, collaborating physician, it may be used, but it's pretty rare. 59610 has to do with antepartum care, delivery, postpartum care, and they've had a history of a C-section. And I do stress you want to give accurate diagnoses. You can't say normal uncomplicated vaginal delivery if they've had a history of a C-section. There is different CPT codes, there's different ICD-10 codes, so you want to differentiate specifically, was there a history of cesarean section or not. 59618 has to do with attempting to do a VBAC and it ends up in a cesarean section. It's mostly going to be a physician. They want to know data statistics between the 59510 and the 59618. So what are all included? We talked in general, but what is antepartum care? Those are prenatal visits. There's a lot of controversy around, is that new OB a confirmation of pregnancy, or is it you starting their initial prenatal care? And that's your office determining how you want to set that up. Some offices will determine prenatal care starts as soon as they consult with me, as soon as they come in. Some offices will do an initial visit to meet and they'll do a pregnancy test with urine or with blood blood, and they'll do the confirmation of pregnancy, and then they'll make the next visit the actual prenatal care. And so there's separate ways to bill. If you're doing a confirmation of pregnancy, that's a primary establishment of care. It either is a new patient or an established patient office visit. Then you start billing the global maternity care after that. Or if you're going to start education, you're going to start doing all the care from that very first visit. It's part of the prenatal visits. Intrapartum care has to do with labor management, inpatient, outpatient, depending on if you're in the hospital setting, birth center, home birth settings. Always remember, a lot of these terms and references have to do with the majority of the medical system billing these charges. So labor management is a controversial one, because if you're referencing the hospital setting, hospitals have nurses and a facility fee that are compensating for that one-on-one prolonged labor support. So some midwives will choose to bill just one flat global care 59400, and there's others, if it's over 2 hours of one-on-one labor support, there are other codes you can bill for that additional, that's outside of global maternity care. Postpartum care starts after placenta is delivered. It is up to 6 weeks postpartum. Some midwives in their area bill home visits separately, because that's above and beyond what the routine medical system does for postpartum care. And some insurance plans will say, nope, that's part of global maternity. You're choosing to go above and beyond. It's an elective. It's a non-covered service. So you just have to know your insurance plans very well in your area, what they define as included with postpartum. But I always tell people, try to bill for everything possible you're offering, because there are a lot of things above and beyond. We provide so much more value and high quality attention. The average doctor doesn't do a home visit. The average doctor doesn't sit and give more than 2 hours labor support. And many times, if you're objectable with the insurance companies, you can easily get paid for what are those separate services outside of global maternity. So what are billable charges during prenatal visits? It's the routine visits all the way till birth. Traditionally speaking, it's around 13 visits, depending on when they start prenatal care. They could start prenatal care as soon as they get pregnant, 6-8 weeks. Some offices start prenatal care at 12 to 14 weeks. They'll do a confirmation of pregnancy around that 6 to 8 weeks, and then they'll officially segment into the new OB prenatal care at 12 to 14 weeks. It's traditionally every month until 28 weeks gestation. Then it switches over to every 2 weeks, and then it will be weekly until 36 weeks on. If you get past the quote-unquote due date, 40 to 42 weeks, traditionally you start seeing them every two times a week. And then obviously, if they need non-stress tests, there's a little bit of high risk going on. Some offices will start seeing them more frequently. NSTs, BPPs, those are separate charges based on a specific diagnosis. Twins, LGA, IUGR, history of diabetes, history of hypertension. You just got to make sure you're giving the appropriate medical diagnosis if you're doing additional services outside of routine maternity care. Some midwives will follow the European model, and they'll more do 4 to 6 weeks apart prenatal visits, 2 to 4 weeks, and then 1 to 2 weeks towards the end, depending on if they've had a baby before, their risk factors, their barrier to accessing services, telemedicine. There's different things you can do to help with that. So main things you do during prenatal care is you're checking their weight, checking their blood pressure. Some offices will do a urine dipstick. There's mixed evidence about that. Fetal heart rate, education, pertinent things along the gestational age they're at. So you're going to do fetal kit count education around 28 weeks. You're going to review RH compatibility at 28 weeks to see if they need ROGAM. At a prenatal initial visit, you're going to get the whole OB prenatal panel. You're going to do a ton of education. 36 weeks, depending if you do home births or birth center or hospital setting, you may have a home visit at that time. You're really doing a lot of education prepping for delivery. Some things are included with education and some things are separate. There's a lot of codes for counseling, a 99404 for breastfeeding, lactation support, postpartum, childbirth education codes out there. There's a lot of things that are extra and above and beyond routine prenatal care and education counseling. So intrapartum is as soon as they're in labor, and these codes are made based on a hospital setting. So if they're admitted to the hospital, you do the initial history and physical. Inpatient, typically they deliver within 24 hours of being admitted. In the out-of-hospital setting, that would be more the time you're triaging them and you arrive at their home and you're doing that initial paperwork, not so much ruling them out if you're going to stay or not. You've said, yep, she's in labor, this person, I'm going to stay here until delivery time, I'm going to start setting up, I'm going to start getting ready. That's that intrapartum management versus a triage home visit. They're in early labor and you'll come back. So you're going to keep an eye on baby and mom during the labor. You're going to check vitals. You're going to do intermittent fetal monitoring if they're low risk, and that's the best option for them. If they're in the hospital, and induction and continuous fetal monitoring, there's going to be different management levels depending on the complexity of the labor support needed. In the hospital setting, they may consider, if there's a medical indication, the administration of oxytocin. They could do some cervical ripening. Those are separate charges above and beyond a labor management that the facility, the pharmacy, will be charging out. There could be the cervical dilators, so you could have catheters, you could have balloons, you can have so many different things to help with the labor process, but most of the midwives are low risk, healthy, and their collaborating physician would manage and bill out those things. And then the vaginal delivery is our goal, but nationally speaking, 35% of families end up the direction of a C-section, and so you would be breaking up the labor support, the triage at home before the transfer. If you're an out-of-hospital midwife, if you're a midwife in the hospital, it would be based on a relationship you have with a collaborating physician. Are you employed? Are you an independent contractor? Are they supervising and processing your claims? Are you guys separate? Those are things you guys would have to figure out when there's that co-management transfer. So traditionally speaking, intrapartum care is going to be from once you start taking care of that person, you diagnose they're in labor, this is the best direction, we're going to have a great healthy delivery, and then once the placenta delivers, then you'll transition to postpartum care. Postpartum care, traditionally, some insurance plans, it's up to 8 to 12 weeks, but traditionally speaking, it's up to 6 weeks postpartum. And there's no hard rules of exactly what postpartum care includes. They just tell you the bare minimum. Most offices in traditional hospital settings, they will do the 2 rounds in the hospital before discharge on a vaginal delivery, and then 3 times before their discharge on a C-section. And then as long as there's no complications, they'll do a visit at 6 weeks postpartum. Maybe the nurse will check on them at 2 weeks on a phone call. There may be some telemedicine just to help with education. They may be scheduled lactation consultants. In the home and birth center setting, there tends to be much more follow-up, because the home birth setting, we're going to be there only for 2 hours postpartum recovery. And in the birth center, it's around 4 hours postpartum recovery. So we're going to do a 24-hour home visit. We're going to do around day 3 to 5 home visit. Traditionally, it's a 2-week visit. It could be in the office, it could be at home, and then the baby will be transitioning care to the pediatrician, the family practice doctor, and the midwife will do the 6-week postpartum visit. So most insurance plans do recognize home visits above and beyond postpartum care, because that's not the routine offerings, but you just have to double check your local payers. And so contraception at 6 weeks, the counseling and education is part of postpartum, but if you're going to administer something, you're going to do an Nexplanon, you're going to do an IUD, some insurance plans will have you do a separate visit outside of the 6-week postpartum, and some will say you can do it the same day. You just have to add the modifier 25. Most government plans will allow you to do the counseling the 6-week visit and then just schedule them the next day, the next week, for a separate IUD insertion, Nexplanon insertion, actual procedure to get reimbursed for that. So what services are excluded from global maternity packages? I get this question a lot, and debates happen often of this is included, this is not. Some of it's up to interpretation. The guidelines are pretty vague on purpose, and you have to remember that these are guidelines. These aren't rules. They're not cut and dry. Every insurance plan determines how they're going to reimburse you. They're going to determine this is a covered service, this is a non-covered service, you didn't have the correct diagnosis, the medical condition affiliated with that procedure. So you have to learn your payers really well. You have to get a good biller on your team so you can learn your local norms and ask great questions. What provider type is on it? When you're talking global maternity, is the home visits included, confirmation of pregnancy, labor support, birth supplies, birth assistant. These are things above and beyond that the facility would charge the other departments that you don't have access to many times when we're doing out of hospital deliveries. So you just want to have really great conversations with them. And I just want to go over the high level examples. A lot of people will use initial office visit to do a diagnosis of pregnancy, primary care visit. So you just seen them last week for a routine prenatal visit. Now she has a cold. Now she has a sore throat, asthma attack, thyroid instability, something new onset that has nothing to do with the pregnancy situation, maybe a chronic condition, new onset, but they're coming to see you. What is the primary diagnosis? What is the reason for that visit? Urgent medical conditions, triage visits, something that's above and beyond routine prenatal care. They weren't scheduled to see you. They asked for you to stop at the home. They think they're in early labor. They think something's going on. This is a rule out triage examination outside of normal business hours. Lab testing, urine analysis, blood sugar monitoring. If you do the A1C, you do finger sticks, you do the lab collection in your office, you do a wet mount. They're worried about having bacterial vaginosis or yeast, an STD screening. Those things are above and beyond. It's not a routine screening. She has a concern, she has a problem, she has a symptom outside of pregnancy. The home visits, you really have to just find out with your payers if they include them. Most of them do not, but they may consider it not part of the copay, just to the deductible versus it's preventative. 59400, if you're in network with the Affordable Care Act, is 100% covered even if your deductible is not met. So some of these separate charges may go towards other aspects, coinsurance, copayment, deductible, non-covered service, just depending on their plan. Non-stress tests, any procedures, anything for a medical reason above and beyond normal, uncomplicated pregnancy care. So non-stress tests for diabetes, hypertension, large gestational age, twins. Some are even doing it for advanced maternal age, obesity. So you just have to have a correct diagnosis. If the claim gets audited and they're asking why you're billing this, you have to have a medical indication to rationalize the above and beyond services. OB ultrasounds, midwives, nurse midwives, certified midwives can bill point of care ultrasounds. We cannot do 20-week anatomy scans, so you would have to just refer that out to a physician, radiologist, local hospital, but we can do dating, we can do biophysical profiles, AFIs, we can do gross anomalies if there's some concerns and problems going on. Presentation, if you're concerned about you're not able to tell from a vaginal exam or Leopold's, and those are billable charges. Newborn care is not part of it. I think that's one that's commonly forgotten with midwives, because traditionally the pediatrician, the family practice, the hospitalist would take care of those charges. Most midwives in the hospital setting don't do the newborn care, and in the out-of-hospital setting they think, okay, I'm giving you global care, I'm giving you global care, and once you start billing insurance, newborn care is separate from global obstetrical package. Breastfeeding support, it's a great counseling code. Many insurance plans, if you're in network, it's covered 100%. 99404 is for 60 minutes. Traditionally, they'll cover about 5 to 7 of those visits. So that's above and beyond. You can still give breastfeeding education. If you're already planning on being there for a postpartum visit, it's different than you just went there for breastfeeding support. You have a lactation consultant on your team. Their primary role is above and beyond routine postpartum care. So postpartum care past 8 weeks, some insurance plans will say 6, some will say 12. So you just have to learn the definition that your payer mix is counting. These are some other things. These are more medical technical things. I just want to make you more aware. If a client comes to you and is asking a question about charges and services, not so much for if you are practicing in the hospital setting, some of these things are going to be a little more common use versus a midwife in the out-of-hospital setting. Fetal contraction stress tests are pretty rarely used anymore, but it could be something an obstetrician determines to decide if we should do an induction or a C-section or further testing. Managing things not related to the pregnancy itself. A diagnosis always needs to be done to support any of your services. If you did a visit and it was more than 24 hours, for example, this is inpatient hospital, you're a hospital-based midwife, and this is a long labor. They were admitted. 24 hours isn't based on our thought of 24 hours. It's based on after midnight. So if they come in at 11 and you do an evaluation 11 at night, and then they deliver the next day, you can theoretically bill, because if it's more than a 24-hour calendar before the delivery, and then postpartum visits have to be done 24 hours from the next day of that delivery. So if they deliver at 2 in the morning on a Tuesday, your next rounding would be on a Wednesday. You don't have to round any more on Tuesday because they already got the services based on billing. I'm not saying clinically there may be indicators to do above and beyond, but just talking on a billing chargeable setting. Every 24-hour calendar window, midnight to midnight. Surgical procedures, if they get a tubal ligation, they have a cerclage, they have anything above and beyond for medical reason to be done, and it's traditionally done by a physician, an MFM obstetrician, those things are outside of global maternity. If you have to transfer or need assistance with a 3rd or 4th degree, the person that's coming in to do that repair is going to charge for that. Contraception management, as you can see, that's different than contraception counseling. So 6 to 8 weeks postpartum, you are going to be expected to give them options, advice, natural family planning, breastfeeding, amenorrhea options, or the traditional hormonal, non-hormonal birth control options. Management is actively placing it, actively administering it. You just have to be careful that it's not the day, most insurance plans, the day of the 6-week postpartum visit. They may or may not pay for it, even if you use modifier 25, because they'll rationalize these two services. Postpartum visit cannot be the same day as a contraceptive management. Have them come in the next day for insertion, for the procedure itself, and do the education counseling at that 6-week postpartum visit. So these are when things get tricky, when someone transfers care, they have a new insurance plan, it's open enrollment, their partner got a new job, they were seen for 2 visits on this one insurance plan, and now they have a new plan. What do you do in those situations? So it's very similar to if they did transfer care. Even though you're going to take care of them the entire time, I want to stress that you have to think that one insurance, if they move from Blue Cross Blue Shield to Aetna, Aetna does not want to pay for services that were rendered before the plan was in place. So if they got a new insurance plan at 36 weeks gestation and you've taken care of them the entire time, you need to bill to their past insurance plan separately. It's not global maternity anymore, even though you're the same provider. You need to bill those separate visits. It may be less than 3, so if it's prenatal visits less than 3, it'll just be the routine office visits. Then it's 4 to 6, and then it's 7 or more. And so you want to make sure you're using the most appropriate. If it's 59425, 59426, you want to just make sure you're billing to the past insurance plan what services were rendered when they had that plan, and then when you get a new insurance plan, whatever services from that point forward. Other times that you would do it is if they're moving away, or they moved into town, or they were seeing another care provider and switched to you. Or the other direction, they were planning on seeing you, they risked out of care, you co-managed, they saw a doctor one time, then they saw you, they're delivering in the hospital, they need an induction, they transferred care for whatever reason. You have to bill for the services you provided, and then whoever you collaborated with, whoever they transferred care to, would bill the other part of it. I always stress to people, be careful, because if they transfer for a C-section, most of the billers aren't going to look detailed at the notes to realize at the hospital that that person is not going to do postpartum visits with that same provider. So they should technically be billing only the C-section charge and not the postpartum care. And a lot of midwives get burned with their claim getting denied because the insurance plan will say there's a duplicate that's already been paid out. And you have to go and be very closely working with the billing department at the hospital because the insurance plan already paid the hospital to do the delivery, the C-section, and the postpartum care because they're rationalizing, and the hospital rounding was the postpartum care, but you're doing postpartum care on those home visits until 6 weeks postpartum. So you have a couple options. You can appeal with the insurance company. You try to get your claim out before the C-section claim is out, or you charge the family a non-covered service saying the insurance plan had duplicated this. I'm providing postpartum care. You need to talk to the hospital, and the billers there, they're billing for services that was provided by our practice. So I've seen it many times. When you're billing insurance companies and transferring care, you want to make sure that whoever is co-managing, whoever is taking care of, they're both on both ends putting their charges in accurately. Because if they're charging for services they didn't provide, maybe they routinely do, but because this was a unique situation and the biller didn't realize it, it takes a lot more work to appeal and correct the claims than just to get them out right initially. So billing claim guidelines, it's just a summary. It's about making sure it's a one-time billing charge for prenatal visits, for labor management for up to 6 to 8 weeks postpartum. There are situations where you need to break it up. There are situations where it's just prenatal, it's just the birth, it's just postpartum, and really understanding what is included and what is not included in global maternity care, because these are large charges. They take time. You don't want to get appeal. You don't want auditing. They a lot of times will ask for additional documentation. So you really want to make sure you file promptly. So global maternity is traditionally billed out the day of delivery, and then making sure that you follow up timely. So if it's been 30 days, it's been 45 days, whatever is the routine average, follow up on the policy with that insurance plan. You want to make sure your biller or your team is calling the insurance plan to find out why it hasn't been paid and processed. Maybe they didn't get it, maybe the clearinghouse didn't process, maybe they want additional documentation, but it's really important to follow up closely with the charges. It's not just submitting it and ignoring it. You have to have a good report auditing system to follow up on claims that can fall through the cracks very easily. The longer you wait to get paid from insurance plans, the less likely the funds will come from the family. It's just a statistical analysis with collections and remaining balances. What did I read from more primary care? Like every month that it goes down 5 to 7%. So if it takes you a year and a half to get paid and they're done having babies and you only do obstetrical care, it makes it a low probability the family will pay you unless they have a really good relationship. So there are some high strategies to do some reverse billing, to have them do a deposit and help with that accountability. But for the majority of cases, you just want to get the claims out right away so you can get paid right away. So there are situations where there's high risk pregnancy management enhancement codes. I just want to make you more aware they exist. I want you to know based on age, medical conditions, pre-existing complications, whether it's with pregnancy, outside of pregnancy. It could be for additional prenatal visits. Once you start getting past 13 visits, you can bill separately for those charges, and you recognize you need to see them extra times because of XYZ. You had some high risk management you had to do with a physician, thinking of extra things above and beyond the traditional maternity care. Most midwives are not going to bill this, but I just want you to be aware it is present in an option. So just as a summary conclusion, maternity care is defined as a bundle. Most midwives, if you're billing insurance companies, we have low-risk healthy clients we serve. We'll take care of them from 8 to 12 weeks pregnant all the way to delivery, beautiful birth, 6 weeks postpartum. So that's just a simple 59400. Once it starts getting tricky understanding what's included in global maternity care, what's separate, they transferred care, you needed some collaboration, making sure you're getting billed and processing everything appropriately of what that insurance plan is defining as global maternity, what is above and beyond it, what's included, what's excluded, what's a non-covered service, birth assistance, supplies, primary care visits, newborn care, birth control management, not counseling, breastfeeding support. The list can go on and on. I think too many times midwives are losing 20-30% of their revenue purely because they're just doing global maternity care. There's so many charges they're grouping part of that code that aren't technically part of that code. So as the business side, I really want midwives to understand what each insurance plan does. Every insurance plan is different. There's government payers, there's private payers. You really just have to learn, well, what are your insurance plans in your community and what are the billable charges? What are the provider types, the diagnosis associated? So you can really, not wanting to do insurance fraud, you want the correct documentation, you want the accurate information, but you want to also get paid for all the services. We as midwives do so much more above and beyond the traditional hospital system, and we don't want to bundle our global maternity mindset of what we all bundle, and that's not the same with billing and coding terms of global maternity care.